So I'm going to talk about an STPA analysis that was done on intravenous patient-controlled analgesia pump. I need to maybe calibrate everyone briefly. This, unlike some of the others, this was not a funded project, and it wasn't anywhere close to a one-year project. This started off as a class project with the students on the right-hand side in a class at MIT that covers STPA and CAST. And after that, we've put a little bit more work to polish some things up and put it into a presentation, but this is really a small scale effort. But I think it's useful to see what you can get. And I think we got some interesting results. So a little bit of background. Another thing I should mention is, unlike a lot of you, I'm not a healthcare provider. I'm an engineer. But even from that angle, I think we can get some useful things out of this. If you're not familiar with these things, there's a concept of pain management, where a patient who is in pain no longer has to wait for a nurse to come and administer something. They just push a green button here, and this piece of equipment will do it for you. So we've, obviously this is safety critical, but we've got safety features. I mean, the manufacturers building these things are not ignorant. At least we don't think they are. They have pump delays on these things. They have lockout intervals, limit on total dosage per time interval. I mean, how can you go wrong with these safety features? Well, somehow you can, because we've got 56,000 FDA reports of problems caused by these drug infusion pumps, about 500 deaths in this 4-year period. 67% of them were due to equipment problems, and the others were operator related. A study was done of these smart pump infusions in hospitals, and they found that 60% of them contained at least one error, and a lot of them contained multiple errors. Of those errors, 65% of them involve violations of labeling and tubing change policies, very preventable, or you would think there would be preventable types of things. 87 of these infusion pumps had to be recalled because there were safety issues that were not anticipated when they were designed and when they were assessed and approved. So we've got some big problems, and this is kind of the easy thing. This is just the pump and equipment. Here are some concrete examples. We've had failures in the tube, clamp, syringe barrel, seals. We've had misprogramming, where a 19-year-old woman went for a C-section and was killed by an overdose due to a program error that mismatched the drug dosage. There was oversedation, extreme oversedation, which leads to respiratory depression and respiratory arrest. At least 15 cases, and this data is about 10 years old, which is about when this effort was done. Drug mix-up, including hydromorphone mixed up with morphine. So really bad things. And this is kind of what might appear to be a simple system. Just, program your dose and very simple control of it, it might appear. But the solution that's being proposed in some corners is to solve these things by integrating this with a lot of other technology to create an integrated clinical environment to oversee these infusion pumps and lots of other things. So we're going to have interoperability between a whole network of these medical devices. We're going to have new safety interlock systems to try to address these problems. We're going to have something that's monitoring a pulse oximeter, which is not normally done by the patient-controlled analgesia equipment. But this integrated environment could do that. It could read from a capnogram. It can detect patient condition, alert clinicians automatically, and maybe automatically, if the clinicians are too busy, stop the drug administration and do other things. So, I mean, kind of maybe from the optimistic view is that this is going to solve all our problems, but I think there's also a valid pessimistic view that's worth considering. Is we better be real careful that if we can't handle a simple infusion pump, we better be real careful that we know how to handle this much more complex system. So let's see how we would approach this type of problem with STPA. I'm kind of assuming that our audience has attended the workshop or has been exposed to STPA before, so we're kind of skipping some of the introduction and getting right to the point. But there are 4 steps, and I'm going to go through these 4 steps. The first step is to define the purpose of the analysis. This involves defining what we call losses and hazards. These are things we want to prevent. So losses might be a loss of life. Of course, we want to prevent that, but there's usually a mission-related loss. Like, what if the patient's pain is not relieved? I mean, why are we even building this PCA pump if we're not able to relieve their pain? There are other losses that we might want to think about from a regulatory or financial or other aspects. Let's stick with the top 2, and we might have hazards. Hazards are system states or conditions that we want to prevent because they prevent the losses. In a worst case environment, they will lead to those losses. So 2 big ones would be that the patient experiences an opioid overdose or an underdose. There are other hazards we might look at, but let's kind of maybe focus on the first 2 to get started. We'll do some more work in this step, but this is enough to set us up in the short time we have to start looking at this problem. So the next step in STPA is to model the control structure. What does the control structure look like? Well, there's definitely going to be a control loop around the patient where we have this PCA pump. It's administering some opioid. It's maybe monitoring. That's a good question. What do we need to monitor? A lot of focus tends to go on the control side. If you don't have a structured method like this, our attention is dominated by, well, the pump. That's what we call the thing, a pump, right? So we're going to have to pump something in. Well, in order for that to work, we better think carefully about what kind of feedback is needed to make those decisions. So here's a control structure that we're going to work with. This is the control loop I was just talking about. We've got the control action, which is pretty obvious. We've got to have some way for that infusion pump to administer some opioid and maybe some ability to stop the pump. Here's the physical pump, which might be seen as an actuator of sorts. It's going to pump something into the patient here. We have this administration and this pain relief that we have with the patient. We've got some sensor. Maybe at a minimum, we need to be sensing the flow rate that we're injecting this stuff into the patient with. So that's maybe a primary control loop to look at here. But we've got another control loop, and that's this one, going through the patient themselves, right? So the patient now has the ability in this system to request and to kind of inject themselves in the control loop, request directly without going through a nurse. I want some pain management, so go. So we've got that control up over here, but we've got higher levels of control. Of course, we've got the clinicians. They're not going to go away. They have to administer and program and configure this PCA pump and set the limits and things like that. We're adding this dotted box here, potentially, at least that's the proposal, this integrated monitoring system, which is going to monitor, not just the PCA pump and the flow rate that it self-reports. It's going to have control, and it's going to potentially stop that guy, but it's going to monitor all these other pieces of equipment we've got in the room with this pulse oximeter and these other things, these vital signs from the patient, and potentially have some automation, make decisions on its own. It's going to have to be configured and programmed by the clinicians. So you might think, are we, in some sense, we may not actually be making the clinician's job easier. That's kind of how these are marketed sometimes. We may actually be making their job more complex. And at a minimum, what we can say, let's get the opinion out of it. What we can say concretely is we're adding brand new control actions that never existed before, and we better have the right controls to make sure that these things we're adding are not going to make things worse. So we ought to think about this control. It's not just programming. That's not just open loop control. What kind of feedback do we need to be providing to clinicians so that they're making the right decisions as they're programming these things or deciding whether we want to turn these things even on or off and enable them? We've got some direct interaction, of course, between a clinician and a patient. We've got some emergency care. There's probably some verbal instructions about how to use this thing and so on. But hopefully we've got protection. So if the patient just starts hammering that button, that green button, we don't get ourselves into trouble. So this is the control structure that I'm going to use for the rest of these slides. I hope what I've described makes sense. I do want to remind you, there are some things looking at this that I still would like to change. This is something, again, it was an unfunded project and kind of something we've done purely in free time, which doesn't really exist very much. So I've got some suggestions myself to improve this if I get a chance to. The patient really is the control process, ought to be at the bottom of the control structure here. And if anyone is in the audience has some other suggestions, let's take it offline. I'd love to hear from you, and maybe we can put some effort into improving what's here. Anyway, let's move on though. Let's just say this is our control structure. Keep in mind, by the way, there's a lot more going on than just this. We can look at the hospital operations management, hospital corporate management, Department of Health and Human Resources in the U.S. Congress. We can go and look at the development of these systems on the left, not just the operations over here, but the development, which has a whole regulatory structure, and engineers are embedded in the control loop, and if they're doing a bad job, which maybe we are because we've got a lot of events that have been happening, we ought to look at where those decisions are happening. They're not happening in a vacuum. What kind of feedback are we giving to those engineers as they're making decisions? Maybe we're not giving the right feedback or information about operating events that are happening. Anyway, we're not going to do that. I just wanted to point it out. Let's go to the next step, unsafe control actions. So we've got a control structure. We've got to analyze this thing. How do we analyze this in a careful way? Well, that's where the steps in STPA give us guidance. We start with the control actions. There's some reason for that. There's an efficiency argument, but I think I'll just move on and say that's the way it's defined. So we're going to start with a control action. One of the primary control actions we would probably pick would be this control action in the PCA pump. It's got some controller that's going to say, okay, go administer this opioid or stop the pump, right? So let's look at that control action. And there's a framework in STPA. If you haven't seen this before, here it is. But I'm kind of hoping that you've seen this before. Let's look at each control action. So we've got this control action to administer the opioid. This is probably an automatic or at least a digital control action that we're looking at down here. Later, we're going to go up in the control structure and look at these other control actions by the humans. But let's look at the machine. So the machine is going to decide to administer the opioid. How could that go wrong? Well, one way is if you don't administer. And how could that go wrong? Well, if you don't administer when the patient is in pain. Now, that is a problem. I mean, it's probably not our biggest problem. We're not going to prioritize this. All those losses and hazards you saw, by the way, I should have mentioned, those can be prioritized. Pain management is probably not the biggest problem. The biggest problem is if we kill the patient. But this is a problem. So this is linked to H2. What else can go wrong here? What if we provide the administer opioid command, right? We turn the pump on when the patient has already been given too much opioid. That'll lead us to H1, our overdose. That's a big problem. We better make sure we've got controls for this. Another thing that can go wrong is we administer it in the right situation, but it's timed wrong. We're administering it too late. Well, that could be an important issue, and we've got to figure out what makes it too late. We've got to define this when we build the system so we know that the system complies and is not going to cause this kind of problem. We can put TBD if we don't know the answer in here. Next column, we look at stop too soon or apply too long. So this applies to control actions with a duration. What if we provide the control action, we turn the pump on, it's the right thing to do, it's the right situation, it's on time, but we turn it off. We don't keep it on long enough. We stop administering the opioid before adequate dosage is fully administered. And you can immediately think of the inverse scenario, which would belong here as well. So we'd populate this table and identify how these things can go wrong. And of course, we have traceability throughout the analysis. These are linked to the hazards, which are linked to the losses. So we can prioritize every one of these. And in a moment, we're going to get requirements. And guess what? The requirements are traceable to all of these things and also are prioritized based on the losses. So let's go to another control action. Let's look at the stop command, right? So we're moving up in the control structure, this integrated monitoring system that's going to network everything we've got in the room together. Let's look at the control actions that we want to prevent, right? And then we'll dive into behind the curtain how those things can actually happen and see if we've got the right controls. So if this integrated system does not send a stop command when the patient has too much opioid, that's one problem. If it does send a stop command when there's nothing wrong, that's a pain management type of problem. If it takes too long to send a stop command, and that could be seconds, we'll have to decide, that could be a pretty big problem. So we'll define these kinds of things, and I think maybe I'll just do I'm deciding now if I want to do one or two more slides like this. You're getting the idea, but I do want to show what it looks like for humans. So we've got clinicians in here. One of the primary control actions here is to administer the PCA pump, to decide to use it and to configure the thing. If they don't administer the PCA pump per prescription or instruction, that could be a problem. If they do administer it, but the patient is not in need, and there's no need for this PCA infusion, or if for some reason the medication is not appropriate, that's a problem. We can think about, what does this mean, medication is not appropriate? It could mean from the beginning that medication is not appropriate. It could mean that something evolves and it's no longer appropriate, right? So we can think about these different classes, but we'll start at a high level, these high level statements. What if we administer the pump too late, if there's some kind of emergency situation or urgent situation? In this last column about the duration, if the administration is interrupted, that's an interesting one. There might be ways that we could do that inadvertently. What if we do it too long after some physician, which is separate from the clinician, after the physician discontinues the order? Ooh, that's starting to get pretty interesting now. We've got this coordination problem. How is the technology going to help or hinder that kind of a problem? All right, and another one that we might look at is, again, the clinician, but again, their oversight of this integrated monitoring system, which is brand new and different from their administration of the PCA pump. So they're now managing a lot of technology, which is different from what they used to be doing. If they program the thing incorrectly somehow, now this is a high level statement, we're gonna get more specific in a minute, but this is a starting point, and so on. Again, we can do this again for the instructions that the clinicians provide. This goes off the screen. This would be instructions to the patient on how to use this thing. We could provide incorrect instructions. We may not provide instructions. Maybe we think someone else did, and so on. But let's move on. That's enough of the unsafe control actions, I think, but you can get the idea. We're basically defining the outputs of these controllers. These are decisions reflected and manifest in actions that we want to prevent. This is part of the problem. Now, immediately, certainly for the technology piece, as soon as we have these UCAs written on the left, we can immediately describe the safety constraints and requirements that we need to be satisfied. Must not send a stop command when the patient has too much opioid. So it has to have that capability to be safe somehow. We must not send the stop command unless there's a good reason for it. We don't want these spurious stop commands and so on. So if these obviously are really helpful for a device manufacturer, but what if you're in a hospital setting? Well, guess what? If you have this kind of analysis for other reasons, for defining procedures that you're going to use, you can still use these kinds of requirements on the right, because you have to select what manufacturer you're going to buy from, what products you're going to buy. This gives you a clue about whether they've designed a good system or not, whether they've covered the bases and met the functional requirements you have. So let's go on to the last step, which is to build scenarios. So this is sometimes where it gets really interesting. How do we take these UCAs, so this is an example of a UCA we just went over, an unsafe control action, and build a scenario from it. So let's look at this integrated patient monitoring system. This stop command can be unsafe. One way it can be unsafe is if the patient has been given too much opioid and we do not send the stop command, right? That's unsafe. How do we build a scenario out of this and get some insight? Well, we're going to use this basic control loop, which is the foundation of STAMP and STPA, right? We're talking about this red arrow, this control action. Controllers don't flip a coin to decide on what control action to issue. Well, at least we hope not. We paid a lot of money so that they're not random processes. They're hopefully deterministic. So why in the world would this IPMS make this decision? Well, without having a design in front of us, we can actually reason about it. We can reason about a process model, a set of beliefs that all controllers in the world are going to have, and we can reason about what they might be and what kind of feedback would inform those beliefs. So let's try it out. One kind of belief is maybe it believes, right? We're humanizing this technology a bit, but it works. It works very, very well without knowing a lot about the design. And before you maybe have that information available. If it somehow believes the patient is in an overdose, sorry, it does not believe the patient is in an overdose condition. Well, of course it's not going to send a stop command. Now, why would it believe the patient is not in an overdose? Well, look at all these pieces of information, right? We can reason about any one of them, maybe a combination of them. One factor that's really interesting and is a common factor is how is it going to piece together on a network all these different devices that may not have been designed from the start to be used in this way. Well, when you've got a lot of pieces of information coming in, you've got to coordinate. And one issue is a timing issue. These things could be coming in asynchronously. They could be coming in, in a way that problems can happen on a network where you have maybe delays that happen in the transmission of these things. So one common practice is to timestamp all these pieces of information. So when you're receiving it, one of the things you would do with lots of pieces of information is check the timestamp. Is this an outdated signal? Was this sent a minute ago, an hour ago, and it's just a delayed signal? So one problem with that control is, what if something goes wrong with the timing of collecting all these pieces of information and putting them together? What if the messages are discarded? And they could be discarded along the network, or they could be discarded by this new piece of technology on purpose, because it's designed to discard messages if they're out of sync or if they're delayed. I mean, that's actually a safety requirement from a lot of manufacturers. Well, that can get us into trouble. So we've got to be thinking about this. Certainly at the device manufacturer level, we've got to be thinking about this. But you know what? Maybe when we select what devices we should go with, or whether we even want this in our emergency room or operating room or whatever, we may want to be looking at whether we want this technology or not. So potential solutions, I mean, there are some engineering solutions that we might want to look at. There may be periodic synchronization checks within the technology that we want to be looking at. So maybe don't just discard things if they're outdated. But I mean, you may laugh at some of these and think that this is obvious, but again, I'll direct you to my second and third and fourth slides where we look at all the events that are happening with these systems. We're having a huge number of events. We've got a broad audience out there tuning in. I want to try to give a message for everyone. This is a very clear message here if you're involved in building this technology. But if you're not involved in building this technology, you are kind of trusting the manufacturer to have done this kind of analysis and done their homework when they're selling it to you, right? Maybe if you're not involved in engineering this, you can require them to do certain types of hazard analysis as part of your supply chain, as part of your buying decision. You want them to be performing some kind of analysis. So maybe if you want to pick up these kinds of things, an FMEA is not adequate. You may want to require some other technique that can pick up these kinds of problems. Let's look at another scenario, one that the folks not involved in the technology might be more interested in. This involves the clinician. So let's take one of those control actions from the clinician. They administer the PCA pump when it's not appropriate. How in the world could this happen? Why would a well-meaning, well-trained clinician configure this thing or turn it on when it's not appropriate? Again, we're going to use the control loop to guide this. We in STPA land, you don't necessarily have an accident that has happened to leverage. So we've got to have some more guidance built into the process to help us build these scenarios before they happen. So how can we do that? Well, all controllers have a process model or a mental model, right? So we can start there. What kind of beliefs could you imagine a clinician having when they decide to administer and turn on the PCA pump? Well, one belief is they believe the patient is in pain, right? So that's part of the reasoning. And what kind of feedback would lead to this belief? Well, they might be seeing the patient complain about their pain, or there might be other less direct feedback that might be interpreted that way. What other beliefs do we care about? Well, maybe they believe that the PCA is already configured and they believe that it's appropriate for the situation, right? Where would that belief come from? It doesn't come out of nowhere. They don't flip a coin. It might come from maybe missing feedback or assumed feedback. They might not be aware that the PCA was previously disconnected for good reasons and make some assumption. Now we're starting to get somewhere, right? So we're starting to build a scenario by using a control loop, right, anchored in the control structure. So here's what we get. I'll jump the gun. Here's a clinician scenario number 9 that came out of this process. The PCA pump is properly configured and it's appropriate, but the patient goes into respiratory depression. There was a problem, and the day shift realizes this, and they responded. They remove the PCA pump as part of their corrective actions, and they override the alarm, which is another response to this. And let's say it makes sense, but then there's a shift change and the patient complains about pain. And guess what? We've got boom, boom. Both of these are now potentially met on the next shift. The clinician is not aware maybe of the previous situation, or if they aren't aware of the reasoning maybe behind it, and they connect the PCA pump. It makes sense to them, and then a patient goes into respiratory depression for a second time, which is really not a good situation. So we can anticipate this kind of thing happening. and we can design potential solutions. Now, there's all kinds of solutions we can think of. We can think of technical solutions from an engineering point of view. What kinds of things can we design into this to help the clinicians do a better job? And beyond the technology, what can we do in the hospital in terms of procedures and information and how we design this thing to interact with the clinicians? We can have the procedures regarding PCA event communication and documentation. We can have this IPMS. Maybe it could automatically record the fact that we turned it off, which might be unusual to turn it off immediately. And maybe it could record that and somehow have an indication that there was an emergency event already for the next shift. So, and maybe when they turn the thing on, if certain conditions are met, maybe we can prompt the clinician and say, hey, are you aware that there was an emergency event a couple hours ago? Or, are you sure? Or maybe we can come up with better ideas even than that. But we should come up with something to try to build safety into our system, and don't rely on people memorizing this or rely on people communicating this in the intent by default. So that's a quick example of how we can use STPA to anticipate future scenarios before they happen. This is my last slide. Conclusions. There's a lot more to do that could be done here, but the conclusions are this works. This provides a path forward to anticipate human actions, software flaws, interoperability issues, captures system level behavior in context, not just physical component failures with a pulse oximeter, for example, captures interaction accidents without any failure at all, accidents where every single part of the system is doing what they think is right, what they were designed and prescribed to do. But we dropped the ball on the interactions. They could be used to develop solutions to prevent these unsafe scenarios and elimination. Like, hey, let's not do it. Let's not buy this technology because we have unresolved problems that are going to take too much to try to control. Or we could try to make sure that the unsafe scenarios we find are at least observable and reversible, really important for a human factors standpoint. This ties in really well with what Wal was talking about in the first presentation. We've got this scenario that's fundamentally not observable until the patient goes into respiratory arrest. That is not a well-designed system. We can make sure that these missing feedback loops are detected before an event and make sure operators and product designers can put the right controls in place. We can also apply this to social aspects, not just to the technology itself. All right, so that's it. That's what I wanted to share. Hopefully it gave you a glimpse at how STPA can be applied in this framework to both the technology and the social side of things. I guess we'll turn it over to questions. I've got to check how we are on time here.